Hello, friends. Greetings from India. Welcome you all for yet another web series, which is the International Interventional Pulmonology web series organized by Yashoda Group of Hospitals, India. So, the topic of discussion in interventional pulmonology today is thoracic ultrasound. And in this, we have talks from two eminent faculties from different parts of the world. The first talk is on thoracic ultrasound in IP perspective by our dear Professor Tudor Thoma from NHS England. Followed by this, we'll have a talk by Dr. Sunita Agarwal from India on the basics and case-based discussion of thoracic ultrasound. In the end, we'll be having the interesting case of the month, where I'll be discussing about a real-world case scenario of a central airway obstruction and how we dealt with it. So without wasting much of the time, we will move on to the web meet for the day. So the first talk will be delivered by Professor Tudor Thoma, and I welcome Dr. Tudor Thoma to give his presentation on thoracic ultrasound and IP perspective.
Thank you very much for the invitation to do this talk. I've been asked to talk about thoracic ultrasound and to give an IP perspective. So I've actually worked to do exactly this. I'm not going to give a lecture on thoracic ultrasound, but I have been trying to give you what I think the interventional pulmonology perspective is on this technique and how thoracic ultrasound can help or influence directly the interventional pulmonologist. We're talking a lot today about robotic bronchoscopy and about busy and high-tech bronchoscopy rooms. I'm using this slide to show you that in 1960s, thoracic ultrasound, or actually an ultrasound room, was a very high-tech room. This is a picture from internet. It's from an American hospital, and you see that the patient had to be in a very special room. It was dipped into a bath to be able to be scanned and so on. However, we all know that the technique has progressed, and the ultrasound system that I'm using mostly in the clinic, on the ward round, and also with me in the bronchoscopy room is this device, which is a pocket ultrasound, and it's one of the devices that has a lot of flexibility in its use, because it has a technology which allows you to modulate the behavior of the transducer as an abdominal transducer, as a cardiac transducer, or as a linear transducer, and therefore you don't need to change the transducers anymore. So even that is a technological progress. And this is not only about the progress. The main advantage is the fact that with this equipment, you actually get the thoracic ultrasound where you need it and when you need it. And this is particularly relevant for our talk in interventional pulmonology, because if you have it with you in your pocket, you can very quickly use it in a variety of circumstances in the IP room. Well, let's look at pulmonology. Nowadays, because of the devices are easy to use and cheap and pocket size, a lot of specialties are using thoracic ultrasound. So it's not only for respiratory doctors. The renal doctors are using to check the water content of the lungs. The emergency doctors are using it for the rapid diagnosis and so on. So with thoracic ultrasound with interventional pulmonology is not about the diagnosis, is not a screening tool. It's a tool which helps the dynamics of the procedure. So it helps in particular with facilitating safe interventional pulmonology procedures, interventional pulmonology interventions. And all this is now aligned with the guidelines that we have in Europe, with the European Respiratory Society guidelines, with the BTS standards. So this is where the thoracic ultrasound helps in interventional pulmonology. And one basic example is when you have the possibility to do very quickly an ultrasound, then you can select the site for a biopsy, do the biopsy, lung biopsy, and then have the result or discharge the patient very quickly. And with that, you actually limit the need for an admission. You limit the use for other more expensive technologies like CT-guided biopsy. And this is just one of the examples. So how does the interventional pulmonologist use thoracic ultrasound and what is different? And in a way, I apologize for this infographic, but I couldn't resist to use the facilities of AI and to generate this drawing, because it does capture basically the essence of the difference between IP and the rest of specialties that are using thoracic ultrasound. So in IP, we're using the dynamic element of thoracic ultrasound mainly than the static element. So for example, for the diagnosis of pneumothorax, we are using the ultrasound to help with the trajectory of the needles, of the biopsy needles, of the insertion needles. And it's also used as a continuous assessment during the procedures. And this is in contrast with radiology, which gives a systematic approach to the examination with thoracic ultrasound, with ultrasound in general. It's different from acute medicine, which is using to rule in or out different pathologies, different diagnoses. And all in all, it helps the interventional pulmonologist to have a more precise intervention and a more safe intervention. And in essence, this is basically the main advantage of thoracic ultrasound. So let's look at some applications and go a little bit more into details of what we can do. And I will focus a little bit on the pleural procedures. I'll mention a couple of things about diaphragm and chest wall assessment. It's very interesting how you can use ultrasound as an extension of bronchoscopy. And I like to say that in effect, interventional bronchoscopy or interventional pulmonology is mainly only about ultrasound. So it's ultrasound in the lung, ultrasound outside of the lung, and ultrasound is key for the interventional procedures. And also a couple of words about pattern recognition and how that would change different interventions. As I said, is not a comprehensive lecture. It's just a point of view which comes from our practice here in London and from the general practice with thoracic ultrasound in IP. So pleural procedures are basically the beginning. They actually initiated the use of thoracic ultrasound on a large scale in respiratory medicine. You all know that now it's basically compulsory to use thoracic ultrasound if you want to do a thoracentesis, and also if you want to do a chest drain insertion. In the UK, there was this National Patient Safety report in 2006, which picked up the fact that chest drains inserted by including respiratory physicians without the ultrasound would end up in different other organs than the pleural space, like heart, spleen, liver, and that made ultrasound being compulsory for pleural chest drain for chest drain insertions. And that's how basically I ended up using the thoracic ultrasound and being actually responsible in the hospital where I work for the implementation of thoracic ultrasound. But that was in 2006. And the reality is that once you start using it for a particular indication, you realize that the benefits of thoracic ultrasound extend far beyond just giving you the location where you can put the chest drain. Of course, the technology, even with the drainage of the pleural fluid, has progressed, and now we have the indwelling pleural catheter placement. We have the studies showing that the management of septations is well guided by thoracic ultrasound. Management of pleurodesis in certain circumstances is also guided and can be guided by thoracic ultrasound. And there is a very good body of evidence, in particular in the UK, the group from Oxford is very active in publishing and also in documenting and doing all this randomized trials for any intervention that you can do in pleural space. But we have a good body of evidence now to show that the thoracic ultrasound in this interventional procedures reduce the risks of complications, reduce the risk of failures, improve patient comfort, and overall is a more effective intervention. We are using it, as I mentioned, extensively in our practice. We have a dedicated pleural clinic where we bring in the pleural pathology, and on a day case basis, we do the interventions. In this clinic, we have a dedicated ultrasound, and unfortunately, the pleural clinic room is not as complex as the robotic bronchoscopy room, but it's still a dedicated specific room that requires again the nurse, the program, and the whole arrangement for this intervention. In terms of diaphragm, for the pleural pathology in particular, it's very common, to be asked by other specialties, by internal medicine, by emergency medicine to drain a white lung. But most of the times the white lung is a pleural effusion, but most of the times it's not the pleural effusion which is contributing to the shortness of breath of these patients. And therefore, we've learned that diaphragm assessment is essential in clarifying whether the drainage is urgent or not, whether it's required or not, whether there is other pathology behind the appearance of the X-ray, which explains the whiteout appearance. Because if the diaphragm motion is still correct, like the diaphragm movement behaves in a normal way, like is going down with inspiration, going up with expiration, therefore the pleural effusion does not have a significant effect on the pumping element of the diaphragm, and therefore is not immediately required to drain that effusion. However, the opposite is true if the diaphragm movement is completely abnormal, if there is no correct pumping movement of the diaphragm, if there is some flickering of the diaphragm, then the drainage is required, and it will make a difference to the symptoms of these patients. To assess the diaphragm with the ultrasound, especially if you have a pleural effusion, is not difficult at all. You just need to think of it and use it basically in your practice. The other thing which we do when we do procedures, pleural procedures, is to assess the chest wall thickening and also the vascularization of the chest wall. Again, we're still using the safe triangle for the procedures, but sometimes you need to go beyond the safe triangle and the technology. Even the pocket ultrasound systems have capacity to use Doppler assessment, and it's very easy to assess the vascular presence and to do a bit of a vascular mapping to avoid the vessels when we do the procedures. This has increased, and again is documented by evidence that has increased the safety of the procedures and also the patient satisfaction with the procedures. An interesting development, if you want, with the use of ultrasound is the dry thoracoscopy. And you may know that Dr. Marchetti from Brescia is one of the promoters of this newly kind of discovered technology. I mean, people in the past were doing dry thoracoscopy, but it wasn't very safe. Therefore, the standard was that if you don't have enough fluid in the pleural space, you would not insert the thoracoscope because there is a risk of damaging the lung, creating bronchopleural fistulas and so on. That's a much more complex complication than just not being able to do the procedure. However, with a thoracic ultrasound, you can easily see if there is pleural sliding. And if there is pleural sliding, that means you can carefully create a iatrogenic pneumothorax by advancing a needle slowly, again, under ultrasound guidance if you want. But, you know, once you have some exercise, you don't even need the ultrasound guidance for this. But the pleural sliding is essential. And if you see the pleural sliding, you can create this iatrogenic pneumothorax, and then you can go ahead and do the thoracoscopic procedure, which has a benefit for the diagnosis for many of these patients for which there isn't an alternative or an immediate cheaper alternative for the diagnosis. The extension as a bronchoscopy, as I said, so initially, and still, unfortunately, people who are like heavy-duty bronchoscopists, many of them very good friends of mine, you know, they think thoracic ultrasound is like a different specialty and we don't need to mix each other, and we need to have like training sort of sessions completely separate and so on. So maybe it's my frustration which makes me stress a little bit the advantage of thoracic ultrasound. So the examination of the chest from the outside of the chest with the ultrasound, not only from the inside of the chest with the ultrasound. From the inside of the chest, I would say that the learning is essentially related to optimizing the image at EBUS, and also to understanding the technology, which is the elastographic assessment of the lymph nodes, and also perhaps the use of contrast. And if you are a little bit more courageous, you can use the EBUS bronchoscope for pleural procedures like endobronchial pleural procedures and all this kind of a little bit sort of niche interventions. However, from the outside of the chest, like the bog standard thoracic ultrasound, has an advantage in the bronchoscopy room to clearly help with selection of the patient for the procedure, because it's far easier to reach a pleural-based lesion with thoracic ultrasound and with a needle from the chest, rather than, and actually much cheaper than to use the robotic bronchoscopy to get to the pleural space or to the pleural nodule from the inside of the lungs. So that would help with the patient selection. And what is interesting is that even if the CT scan or the radiologist from the CT scanning is reporting that the lesion doesn't have a direct contact with the pleural space, so the assumption is that you would not see the lesion on the ultrasound, I would strongly encourage you, if the lesion is definitely at the periphery of the lung, to use the ultrasound in that area and to try to find, try to localize the lesion, because the ultrasound is much more sensitive for detecting this tissue, and it might be visible from the outside, and therefore the biopsy, the insertion of the needle from the outside is much it's easy to do, and again it's cheaper. The correlation with the endobronchial ultrasound, yeah, it may be helpful. Yeah, I mean, it depends on what the pathology is. I think the main benefit here, the main additional benefit is this on to say when the endobronchial biopsy is not necessary. And the other main benefit, which is very helpful for even for the trainees, is to quickly diagnose a complication related to a transbronchial biopsy or to a peripheral biopsy there and then in the bronchoscopy room, without the need to move the patient to radiology or wait for the radiology to approve an X-ray and so on to diagnose if the patient has a pneumothorax. The ultrasound is it's very sensitive to say that the patient doesn't have a pneumothorax, and therefore it's very helpful for this procedure. I think we need to look at research and development in this area, because if we look, for example, there is a paper which shows that the elastographic use of thoracic ultrasound can help visualizing peripheral lesions which are not in contact with the pleural, with the pleura. And that may open up the possibility to target a peripheral lesion with thoracic ultrasound, just using the elastographic appearance. And then there is also the potential to use contrast, which also has a role in peripheral lesions. And the contrast may help you decide where to put the needle, to avoid the necrotic areas. It can characterize a lesion if it's likely to be benign or likely to be malignant. And it may light up, it may show up other lesions which might be smaller and still peripheral and helpful for the diagnosis. So my bottom line here with this slide is, don't dismiss, my friends from pure interventional bronchoscopy, don't dismiss thoracic ultrasound, because it's synergistic, I think, with bronchoscopy, and it can help. And one other thing which I need to add, which is also interesting and important, with the advantage of having now more and more the use of single-use ultrasound, single-use bronchoscopy, so single-use bronchoscopy systems, we can actually use safer single-use bronchoscopy in remote areas where there isn't a bronchoscopy room, where we don't have access to radiology after a procedure, if we have a pocket ultrasound with us. So I think this combination of a single-use bronchoscope with a pocket ultrasound can open up the possibility of doing minor interventional and diagnostic procedures in remote areas or in hospitals where otherwise there isn't an interventional bronchoscopy unit. And that's not to say that we need to do everything in these peripheral centers, but we can stratify and we can, do what we can in the periphery and reserve the use of the expensive interventional bronchoscopy or pulmonology rooms for more complex patients and complex procedures. This is basically the slide which illustrated my talk from the previous slide, which shows that it's very easy with this pocket ultrasound to demonstrate pleural sliding, and therefore the patient doesn't have the pneumothorax, and we can move on, and it's a safe procedure. So we can be sure that the procedure was not with complications. Just a couple of words about pattern recognition. What does this mean? I mean, we use pattern recognition for diagnosis. Again, interestingly, ultrasound is very helpful for diagnosing patterns suggestive of interstitial lung disease, and therefore it will help with the diagnosis of interstitial lung diseases, and then we can go and clarify this diagnosis with a cryobiopsy and so on. However, I said I'm not going to stress the importance of ultrasound in diagnosis, but more into procedures. The patterns which are important for the IP persons, for IP people, are those related to pleural thickening, the complex septated effusions, and whether they still benefit from some drainage, or you need to make a referral to thoracic surgery, or the decision to do a thoracoscopy is helpful. And also to clarify some aspects of subpleural consolidation, which again will change the management, which may look like an effusion on the X-ray. So these patterns are important, and therefore the common mistake here is to treat every anechoic space as a drainable fluid. I think that needs to be treated in the clinical context, and the decision should be taken into consideration considering the rest of the investigations as well. It might very well be a cystic lesion or some other pathology which requires basically an endoscopy, not necessarily a thoracic ultrasound procedure. So how do we do training? I think this is another important aspect, because training in thoracic ultrasound has to follow the same principle as training in interventional pulmonology. And that's why people who are doing training interventional bronchoscopy are also people who are doing very good training in thoracic ultrasound. The element of outcome-linked learning, mastery type of training, rather than just adding some numbers to procedure, and also the element of eye-hand coordination, which is essential for interventional bronchoscopy, is also essential for thoracic ultrasound. And people who are coming from different backgrounds, coming into the training of thoracic ultrasound without the training, without the knowledge of interventional pulmonology, end up missing essential elements that make a difference in the training of these procedures. So what do we do in London? We are having a dedicated course. We've done elements of this course with you guys in Yashoda when I came to the Broncos meeting in the last couple of years. However, what is new now and interesting is the use of artificial intelligence as a mentor who would guide the trainee in doing correct procedure, and not only in doing the correct procedure, doing a course, but what's more important is doing the procedure when the trainee, when the student is now in his institution remote from the place where the course was. And for example, the trainee will have additional questions, which are technical questions. How do I do, how do I optimize this image and so on, which normally is resolved by maintaining a contact with the faculty during the course, but that's not always very practical. So having these mentors who are basically AI GPTs using the knowledge base of our educational material. So not everything from the internet, but a specific knowledge base. Then that GPT can give a very competent answer to the questions the trainees have. We also encourage them to keep a logbook. This is an example of a logbook. And again, with this logbook, you have the possibility to go through different scenarios, reviewing, do like case-based discussions. And this is something which we use mainly for the people who are working with us for a period of time, because we are doing it more or less in presence, face-to-face. The other advantage of AI is now that you can create, as I've shown you at the beginning, dedicated infographics, which you can insert in this notebook. And therefore, the next project here is to create the notebook with one page for documentation and one page to have like an infographic about the particular aspect of thoracic ultrasound, which again is something that can be used for interventional bronchoscopy as well. It's again a possibility only made available by the fact that it's so easy now to create this infographics with applications like Gemini AI. Right, so towards the end, I need to mention a couple of words about governance. All these procedures, because are done with a pocket ultrasound, so sometimes we miss the opportunity, if you want, to do the documentation, but I think we need to document, in addition to what we document at the bronchoscopy, the fact that we've done a point of care ultrasound or a thoracic ultrasound to the patient. So we need to be absolutely sure about the documentation standards, and that is very important. Then the other thing which is important is what is happening with the imaging. Unfortunately, in the UK, it's a very strict embargo on using patients' imaging for internet applications and things like shared platforms, including Facebook and so on. So, which I think in a way it's unfortunate, because it does really help exchange, but it has its risks as well, and therefore we have a strict protocol for image archiving. That's also linked with the consent. So when we do consent for bronchoscopy, we consent for image archiving, image collection. And it's also important not to forget that sometimes CT is required in these patients, and it's very easy, to become extremely enthusiastic, maybe as I am on thoracic ultrasound, and deny the fact that some patients do actually need a CT. One example I'll give you is for patients with pneumothoraces, which are difficult to drain. You would still need a CT, which gives you a panoramic view of the structure of the lung, where the pathology is, where the problems still are. So I think that's important. Couple of words of where the field is going. So I mentioned AI. We have now a machine, an ultrasound machine, which is giving AI-assisted instructions in terms of image acquisition, not only image interpretation. I think image interpretation is not very difficult, and you don't need necessarily AI to tell you that this is fluid, or this is a septated pleural effusion, or that this pleura is sliding or not sliding. But for applications where the image acquisition is more complex, such as, for example, for the diaphragm, if you want, or again, in the general clinical practice, when we do multi-organ ultrasound for the diagnosis of patients with dyspnea, looking at the heart, image acquisition of the heart, even if you do a focused cardiac examination, is a little bit more complex than the respiratory image acquisition. And I think that's where the AI is helping. My experience with AI-guided image acquisition is not that it will help you immediately, directly. It will tell you where you may improve, but then you still need to improve a little bit by yourself, if I may say so. So you need a bit of practice. It's not, it's not like transforming you into a robot and then you'll be able to do a perfect image acquisition because AI is telling you how to do it. I think you still need to assimilate the maneuvers and the muscle memory of how to acquire the image, and therefore a little bit of practice on a simulator after that, or even a practice on a patient in a safe environment is important. Very interesting is the fusion imaging with the CT. This is coming again from cardiology. We are not using it yet I haven't seen it used in respiratory, but maybe it's just my limitation. Certainly there are some still unresolved questions related to the whole field, like who should be allowed to use this pocket ultrasound? Can a nurse do it? Can the cardiology do the thoracic ultrasound and so on? This is an ongoing discussion. I think in the end, it will be like the stethoscope, or if it won't be, it will be very similar to that. We will therefore need evidence for thresholds for the competency training and diagnostic thresholds for all these new indications that we may be able to see. So these are, again, discussions which are coming into all the questions that we get when we do these presentations, mainly to a general audience and to our managers. In terms of AI, a field which is very close to my interest and heart is the possibility to expand the image interpretation with AI. And at the moment, we have this B-line sort of assessment, which is an AI assessment of B-line. But I think if you look at what AI can do, you can easily transform a two-dimensional image with a couple of additional sections into a three-dimensional image, and therefore you can have like a thoracoscopic exploration of the pleura, which is a virtual thoracoscopy just from an ultrasound capture. It may also help to diagnose different types of effusions. I think this is a very interesting area for research and for exchange of experiences. So something that we need to look up for in the future. Another area which is interesting is this, which is the plaster-based like ultrasound, and I'll briefly explain you why this is possible. The pocket ultrasound that I've shown you at the beginning, the butterfly system, does not use a piezoelectric crystal. They use a silicon membrane with a matrix of 9,000 tiny little speakers that will generate the ultrasound. And therefore, technologically, it is possible to completely separate this membrane from the bulk of the rest of the electronics of the ultrasound machine. So here people have done basically the membrane into a plaster that can be attached for a period of time on the body. And this behaves like a proper ultrasound machine and can be modulated like an ultrasound machine, which is again modulated like an abdominal probe, linear probe, or a cardiovascular probe. For the interventional pulmonology applications, I don't have something to tell you immediately. I can't see it immediately as being useful. I see it, for example, for monitoring patients with interstitial lung disease under treatment. So you can put this on a long-term basis on somebody's chest and give the treatment and see how the B lines and the density of the lung changes with the treatment or with the interventions. I think it's a very interesting development of the technology. It also probably reduces the cost of the ultrasound, and it's something that we need to watch out. So I will conclude with the following. I think thoracic ultrasound is very useful as a procedural tool, not only as a diagnostic tool. And we who are interested and have a pedigree in interventional bronchoscopy should adopt this as well as other bronchoscopy tools. Yes, I don't think we should make this separation between bronchoscopy and thoracic ultrasound at all because it's not constructive. I think the thoracic ultrasound gives interventional values in the dynamic process of making decisions during procedures, which is very, very helpful, especially for the safety of the patient, for judging whether there is a complication or not. And I also think that we as interventional pulmonologists are better suited for training thoracic ultrasound to our specialty, to the interventional pulmonology group, but also to the general specialties and the general respiratory group. And that's why I think it's important to stay close to the other teams who are doing POCUS training for other specialties, and we're actually combining, and this is what our course has evolved. So we started with thoracic ultrasound, now is thoracic and multi-organ ultrasound, where we have people from cardiology, from renal medicine, from emergency medicine coming to talk to us about scanning other organs as well. So this is a list of references. I didn't use references for each of the slides, but this is a summary of the most essential references of my talk, which you can study with or without AI at your leisure. Thank you very much for this presentation. I'm sorry I'm not in person, but I understand these are some webinars. I'm happy to take any emails, questions by email from the audience. And I don't think I have a slide with my email, but my email address is toma@doctors.org.uk. Thank you very much.
Thank you, Professor Chudatomo, for an excellent talk on thoracic ultrasound in IP perspective. I think you gave a lot of insights about what could be the future of thoracic ultrasound and how we are going to see this domain evolving in the near future. So now we move on to the next talk, which is to be delivered by Dr. Sumita Agarwal from India, and it will be on basics and case-based discussion. Over to you, Dr. Sumita Agarwal, for your talk.
Hi. Good evening, everyone. Today, I'll be discussing thoracic ultrasound and its implication on a case-by-case basis. First and foremost, let's understand before moving to case, it's important to know your patient's clinical history, know your patient's vitals, so that you have a differential diagnosis before your ultrasound, not after. How is thoracic ultrasound important in emergency? It helps us in coming to a diagnosis whether the patient is for respiratory failure there is a cardiac cause, there is a hypovolemic or a circulatory failure. So the cause of that we can understand. And it is helpful for inserting of your central lines for diagnosis of pulmonary embolism as well. So today we'll be understanding the most important signs that we need to know, depending on which you will be making the diagnosis for a patient who is coming to the emergency or the patient is in ICU. And by these simple signs, we can make a bedside quick diagnosis. So the most important 10 signs that we need to understand today are, first of all, the batch sign, the pleural line or the A profile, which I'll be telling you. Then the lung sliding sign, the seashore sign, the A lines, how do they look like? Quad sign or the sinusoid sign, which we see in cases of pleural effusion. Then the fractal sign or the shred-like, tissue-like sign, which we see in cases of lung consolidation. The B lines, which we say in the form of lung rockets, that's how we see them. And they are typically seen in cases of interstitial syndrome. I'll go through with what I mean by interstitial syndrome. And when your lung sliding is absent, so we'll see what lung sliding is. And when your lung sliding is absent, what is stratosphere sign? How is that implicated along with pneumothorax? What is lung point, the gold standard for diagnosis of pneumothorax? And what is lung pulse? Lung pulse dynamic air bronchogram that you can use to distinguish between atelectasis from pneumonia. So, but why are we so much focusing on USG? So all of these signs that we just saw, they were assessed using CT as the gold standard. And the sensitivity and specificity of these signs have ranged from 90 to 100%. So it is a reasonable bedside gold standard. In your critically ill patients, when you cannot shift them for a CT scan or for other modalities of investigation, when you cannot shift them, ultrasound is a very easy and a bedside, most important that you don't have to shift. It's a bedside assessment available. In a very quick time, like in a very, like less than 3 minutes, you can assess the cause and reach to a diagnosis as to why the patient is having respiratory failure. And that's where the blue protocol comes in picture. Blue protocols helps us in diagnosing what is the cause of respiratory failure. Diagnosis for acute circulatory failure. That's where we see it what the false protocol is. And it's bedside and no radiation. So that's why we're so much focusing on the USG part. And then that's how we'll come to the diagnosis depending upon the study of blue protocol. So before understanding the blue protocol, we should know that where are you going to put the probe on the patient to evaluate for these signs. So as you can see on the anterior chest wall, these are the 4 points. How do we locate these 4 points? By placing 2 hands on the anterior chest wall with overlapping your thumb, and the central point of this hands becomes the first 2 points. Similarly, in a symmetrical area, the next 2 points. So this 4 points on the anterior chest wall, and on the then there is one more point called the flaps point, which is your posterolateral point, which we do at a posterior junction, posterior to your like the posterior axillary line on a lateral side over here. So this is your flaps point. So moving on to the signs now. The first sign that we are going to study is the A line or the batwing sign, the sliding sign. What do we mean by seashore or the A profile? So the first picture over here that you can see is the B mode. This glistening white area, that white line that you can see is the pleural line. In a normal lung, when the lungs are expanding during your inhalation and then the expiration is happening, this lung slides over the pleura. So you can see this as a pleural sliding sign. The horizontal lines that are coming downwards as artifacts, they are called the A lines. And then the ribs, they do not cast any kind of shadow over here. So you can see 2 black images on the lateral sides. This gives you a typical batwing appearance. So with the sliding sign, this is the normal lung that looks like. And when you will take this B mode into M mode over here, what we can see is, so this upper part over here is the part of the chest wall which is not moving that much, so it gives you a barcode like appearance. This is again your pleural line, and then the lung which is sliding over the pleura gives you a the seashore like of the appearance, the shore of the sea. So this entire thing, because over here you can see the barcode sign and pleura, and then over here we can see like this, the sand of the beach. This entire thing is called as a seashore appearance. Right. Moving on to the next sign, the quartz sign or the sinusoid sign. So whenever between the two layers of pleura there is fluid present, like this, the black area over here is a fluid present. Whenever there is two layers of the pleura separated by fluid, you can have an image like this. And when you make a border at this place, at this fluid area, then you can come to a picture like this, which is called the shape of a quadrangular. So it is called the quartz sign. When you put this B mode into M mode over here, what we can see is the stratosphere sign of the barcode upwards, and then the sliding lung and the visceral pleura, which is sliding and making a sinusoid kind of picture because there is fluid over here. So lung moving, fluid over here, and the barcode here gives you a typical sine wave pattern of the sinusoid sign. Also over here, when you can measure the distance between the pleura from the chest wall. So you know how much depth you have to insert your needle to for doing a diagnostic fluid tap. A distance of 10 mm or 1 centimeter is considered safe to insert your needle. So minimum of that distance you have to calculate. If that is there, you can definitely insert a needle even in this small amount of pleural fluid. So traditionally, the fluid looks anechoic. In more severe cases, it can look echoic, like in cases of empyema or a hemothorax. For pleural effusions, now ultrasound is like highly sensitive. It has a sensitivity of 93% and specificity of 97%. So even a minimal amount of fluid can be detected with ultrasound. Also, we can do a guided aspiration of the fluid. Moving on to the next sign, the fractal sign or the Schrett's sign or C profile. Now, this kind of picture is seen in cases of lung consolidation pneumonia. So we know that when the lung is consolidated, there is no air going inside, the lung becomes almost solid-like. So over here you can see this part over here is the spleen. And the lung is having the density as good as that of the spleen because there is no air here, it is filled with secretion, so it is having the same density. This is known as the fractal sign when the entire lobe is involved with pneumonia. When the entire lobe is not involved, sometimes you can just give this marginal shred-like picture, and this is called as a shred sign. And both of this picture, either of them, if you see on the ultrasound, it is called the C profile. So a tissue-like sign seen in translobar consolidation, shred-like sign seen in non-translobar consolidation, having a 90% sensitivity, 98% specificity. Now in this only, if you see a dynamic air bronchogram, or if there is a lung pulse, that means if you can visualize heartbeats at the pleural line through a non-inflating lung, then they are very much diagnostic of pneumonia and you rule out atelectasis. So as I told you that in consolidation, what is happening is there is no air going inside the lung. That can happen in cases of atelectasis also. So to distinguish between pneumonia and atelectasis, if you see signs like dynamic air bronchogram or lung pulse, then it definitely distinguishes between the two. Almost gone. The multiple rocket-like structures coming from the pleural line. This is called as the beat. Over here, you can see the multiple in the space over here. On the other hand, what can we see here? That there are these vertical lines we can see, but A lines are still present. And not all of these lines are arising from the pleura. So these are artifacts and they don't really signify any other underlying pathology. So what is B line? B line is a comet tail artifact which always arises from the pleural line. always used in concert with lung sliding. Almost always long, well-defined, laser-like, hyperechoic, erasing A lines distinguishes it from all other comet tail artifacts. 3 or more B lines between two ribs, they are called lung rockets. 3 or 4 B lines called septal rockets. So they correlate well with curly B lines. Twice as many, they are called ground glass rockets. They correlate with ground glass opacities. So only anterolateral lung rockets, if you can see, then they are usually because of posterior interstitial changes, which can be due to gravity alone. So they are not to be considered pathological. So important again is that because of this different ways of distinguishing of the B lines, you can also distinguish whether this patient is having a hemodynamic pulmonary edema or ARDS or COPD. You can rule out pneumothorax. How we will do, we will see it in one of the cases, and that's how I told you how we will distinguish between all of these things, right? So when we are saying like curly B lines, we know we're talking about pulmonary edema. But when there are too many ground glass opacity like, which we see in cases of ARDS, okay. What is there over here in this picture? We're talking about absent lung sliding. So I told you what lung sliding is, that your lung, which is inspiring, expiring, the air is going in and out, the lungs moving. You can see pleura, the lung is sliding along the pleura. When the lung is not sliding, that can happen in multiple cases. I'll be discussing that subsequently. And that case, you will not see the sliding sign present here. And when you put this in the M mode, the seashore is absent and the entire area which is not moving, that's why it is replaced with the barcode kind of a picture, also known as the stratosphere sign. This kind of picture is seen in many conditions. One of the common conditions that we see it in is pneumothorax. But your lung can be absent, sliding, because there is no air moving in and out. That can happen in other cases also, like the inflammatory adherences, like ARDS, or in cases of atelectasis, like major atelectasis can happen with one lung intubation. Chronic adherence, fibrosis, chronic palsy, the diaphragm is not moving, so the lung is not moving. Sometimes in jet ventilation, cardiopulmonary arrest, apnea, if there is an esophageal intubation done. There are like inappropriate settings, some inappropriate probes, frequently in critically ill patients, and can be multiple reasons of absent lung sliding. Important to understand is that if there is lung sliding present, then it has a 100% negative predictive value for pneumothorax. So if your lung sliding is present, you are sure that there is at least no pneumothorax. Then how do we conclude pneumothorax? If you can see lung point, what is lung point? It is one point where on one side you will see the lung sliding absent. On the other side, the lung sliding will be present. Sorry. Okay, so when you put this again on M mode, it will look like this. The lung slide present will give you the seashore appearance, and absent will give you stratosphere appearance. So this, if you find a point where you can see both of these things happening, then we are sure that this is a case of pneumothorax. So let us understand the different the terminologies that Blue Protocol uses. A profile is when you have lung sliding with A lines. A dash profile is when you have A profile with abolished lung sliding. B profile is when you have got lung sliding along with lung rockets. V dash profile is you have V profile with abolished lung sliding. C profile is seen in cases of lung consolidation, regardless of the size and number. A thickened irregular pleural line is an equivalent. If there is a A-B profile, that is a half A profile at one lung and half B profile at another, that also indicates your pneumonia. You see that again in this flow chart. Now, so depending upon the different terminologies that we have understood, let us try to understand how will we come to a diagnosis. So this is the flowchart of Blue protocol, where the first thing that we have to see is whether lung sliding is present or not, which these things we see in the upper and lower anterior chest wall points that we saw in the first slide, the first few slides. So if your lung sliding is present and if there is a B profile, then this is a case of pulmonary edema. It can be cardiogenic or non-cardiogenic, depending upon patient's history, clinical findings, and then the number of B lines. As I told you, 3 to 4 usually indicate curly B lines. But if there are multiple, they indicate ARDS, ground glass kind of opacities, interstitial, ARDS or acute interstitial lung injury due to any cause. Suppose if your lung sliding is present and there is an A profile, that means there is no underlying lung issue, then we move sequence analysis. So you will look at your IJV and femoral and see if there are thrombused veins present. If thrombus veins are present, then this patient may have pulmonary embolism. If the veins are free, then you go and study your PLAPS point, which is your posterolateral point. And when we see on the PLAPS point, if you can, then this patient may have exacerbation of COPD or asthma. Now coming to a situation where your lung sliding is whether present or not present, but you have a C profile or AB profile. That is a case of either pneumonia or your atelectasis. And in that case, if you can see that dynamic air bronchogram or your lung pulse, you know that you're dealing with pneumonia. If this is abolished, your lung sliding is absent. That means you're seeing if there are lung sliding absent and there are B lines, that means what we're dealing with is the B dash profile. The patient has pneumonia. If it is an A dash profile, and if you can see the lung point, then it is pneumothorax. But without lung point in such a case, we need to understand what is the other cause, and for that you will need other diagnostic modalities then in that. So let's do this case that we are all waiting for. And with this case analysis, I will show you how we can reach to a diagnosis using any of these things. So this patient, a 66-year-old male, diagnosed as COPD. He was on therapy. He complains of increased dyspnea for the past 3 days, cough for the past 3 days, and he has come to the emergency with respiratory distress. His respiratory rate is 28, pulse is 126, and his room air saturation is 82%. So what can be the differential diagnosis for this patient's acute respiratory failure? The 5 P's of acute exacerbation of COPD: pneumonia, pneumothorax, pleural effusion, pulmonary embolism, or pulmonary edema due to cardiac. All 3 C's, the cardiac tamponade dysfunction, your RV dysfunction, or arrhythmias. Now let's see, what are you going to do with the Blue protocol? So what was the first question in the flowchart? First of all, you have to see whether lung sliding is present or absent. Let's see over here. What do we see? The lung is sliding over the pleura. Lung sliding is present over here, right? What do we see here? The lung is not sliding over the pleura, so your lung sliding is absent. And you can see here on the M mode, it's a complete barcode. Okay, we cannot see the seashore sign. So, lung sliding is present, and what we are seeing here, a lot of B lines. So it is a B profile. So with so much of with the lung sliding present and B profile, our diagnosis is pulmonary edema, which can be cardiac or non-cardiac. If the lung sliding is present and you see A profile, as we discussed, we will be going to the venous analysis. So let's do the venous analysis now. Okay, so we'll do the venous analysis. And what are we seeing? There is a thrombus present. So what is the diagnosis then? Pulmonary embolism. which can be due to cardiac arrhythmias, or we need to find out the cause in that case. But what if there is no thrombus? You move on to the Plaps point. What are you seeing here at the Plaps point? Let's understand. Plaps point. What are we seeing here? There is what sign? There is some amount of effusion. There is also a C profile kind of scene over here. So this patient has got pneumonia along with underlying tooth effusion. Over here, when there is nothing at the Plaps point is normal, then it is an acute exacerbation of your asthma or COPD. Now, moving on to the situation where lung sliding is absent. In that case, again, we see if there is an A' profile, and what we're seeing here is a classical lung point, right? You can see that the lung is sliding over here. There is a point, and then the lung is not sliding over here. So we have a diagnosis for this patient. It is a case of pneumothorax. Without lung point, we will need other diagnostic modalities to come to a conclusion. Right. Now, what if there is B' profile? So lung sliding absent, a lot of B lines coming. What is the cause? Pneumonia. So you've seen all of these signs and you've not come to any diagnosis. Then the thoracic ultrasound can also be used to do a quick cardiac assessment. And cardiac assessment then can tell you the cause of dyspnea, or in many cases, the cause of circulatory failure. So over here, in the first that we can see is fluid accumulated in the pericardial space, the cardiac tamponade. So this patient has got a pericardial tamponade. What we can see here, so there is an RV dysfunction. Now this can happen in cases of, again, acute embolism, COPD, col pulmonale, in those cases. And here what we can see, left ventricular dysfunction. So a bedside USG you can use to assess your thoracic causes, lung causes, as well as cardiac causes of acute breathlessness or circulatory. How do we assess further about circulatory failure? You can also assess the IVC. This is a normal IVC. It is dilated. A normal is dilated up to 2 centimeters and less than 50%. So 50% collapsible is normal. Over here, you can see that it is less than 2 centimeters and more than 50% collapsible. So patient is fluid is underloaded, so he needs a lot of fluids. Maybe in this we can see your dilated IVC, more than 2 centimeters and less than 50% collapsible. This also can be done on a bedside ultrasound. So this is a summary of the new protocol as we discussed. A lines with no lung sliding and lung point present pneumothorax. A lines, lung sliding present, nothing on your Plaps point, COPD asthma. But if you've got a DVT, pulmonary embolism, in cases of B lines, present focal B lines, it can be consolidation, or if there are diffuse B lines, then it is there can be cardiogenic pulmonary edema. You can see whether there is associated effusion present or not. In cases of C profile, if you can see air bronchogram, then we know there is pneumonia. And if we cannot see an air bronchogram, then it still can be pneumonia or some other causes of consolidation like atelectasis going on. As I told you, you can also use the Falls protocol then to understand whether this patient is having acute, what are the causes of acute circulatory failure. So Falls with blue, if you combine, you can totally assess. So simple emergency cardiac sonography you do in cases of acute circulatory failure, you can see whether there is a tamponade present, embolism present. On the blue protocol, you will see whether there is a pneumothorax present. Then you know that you're dealing with an obstructive shock. If you're seeing B profile here, you know you are dealing with cardiogenic shock. If all of this is fine, it is A profile, you see your Falls protocol, and then you see if the patient requires fluid. If the patient is improving on fluids, then this patient is hypovolemic shock. If there is no improvement, you give fluids and B profile generated, usually this patient has got septic shock. So by going through all of these various signs quickly in your patient, we can come to a quick diagnosis and hence start with the therapy. So I think that is where I end here for now. Thank you so much for the patient.
Thank you, Dr. Sumita Agarwal, for an excellent case-based discussion on thoracic ultrasound and giving real-world insights on how do we deal with patients on day-to-day scenario. So with this, we move on to the final part of the web meet today, which is the IP case of the month. And here I will be discussing about a real-world experience of how we handle a case of central airway obstruction with the help of the rigid bronchoscopic instruments. And we'll take you through a real OT experience on how we do it. And in the end, you will understand what are the precautions that are to be taken and how you should be prepared in handling such airway emergencies. From the unit of from the Yashoda Hospitals, Somajigada, we will be demonstrating you a case of rigid bronchoscopic tumor debulking. So as you can see from the video here, I am intubating my patient with a rigid bronchoscopic barrel, and the barrel size is 14. So now you can see that we are able to smoothly negotiate the rigid bronchoscopic barrel into the trachea, and we make sure the rigid bronchoscopy is in place. So we have this patient who is a 50-year-old male with a suspected left upper lobe tumor. Now you can see that I'm passing a suction tube onto the left side, so that in case when I'm doing a tumor debulking, there is a bleed, it can help in suctioning out of the blood. This is a technique which we generally follow in our setup, where we introduce the Fogarty onto the contralateral side, so that we occlude it while doing the tumor debulking, so that the blood spillage does not happen onto the contralateral side, so that we can make sure that the ventilation takes place appropriately. Now you can see my assistants in the PIP inflating the balloon to check the integrity of the balloon. So and right now we have made sure that all the precautions are in place, and now we will go ahead doing a tumor debulking. Now you can see that I'm passing the scope onto the left main bronchus, and here you can see there is a big vascular tumor which is causing the near complete occlusion of the left upper lobe, and it seems to be a pretty vascular tumor. So as you can see from here, the vascularity of the tumor is significant. Therefore, we anticipate quite some bleeding while doing a tumor debulking. So what I'm doing is I'm taking a adrenaline, a diluted adrenaline, and I'm instilling it over the tumor so that it can decrease the vascularity to a certain extent. And along with that, we also tilt the patient slightly to the left side, so that while doing the tumor debulking, if there is a possibility of an airway bleed, it just remains onto the left lung and does not contaminate the normal lung. So once it is done, now you can see my assistant is giving me the electrosurgical snare, and I make sure that the settings of the electrosurgical snare are in place, and I inform my anesthetist that the FiO2 should be less than 0.4, so to avoid any sort of airway fire while doing the electrosurgical snare. We also make sure that the electrosurgical snare is in working prior to the procedure to avoid any sort of technical glitches. And now you will be seeing that I'm introducing the electrosurgical snare through the working channel of the bronchoscope, and my assistant is helping me, will be helping me in snaring this vascular tumor. We generally prefer to use a hot technique prior to cryo extraction to decrease the amount of the bleeding. Now you can see as I pass the electrosurgical snare, the snare comes out of the lower end of the bronchoscope, and now you can see that I'm asking my assistant to open the snare, and you need to be very gentle in making sure that the snaring is proper. If not, you may end up partially snaring the tumor. Now we have got a very good loop over the tumor, and right now I'm instructing my assistant to closely snare this tumor, making sure that we have a good coordination between myself and my assistant. Now you can see that I'm slowly snaring the tumor. So So go ahead for the snaring, please. See, right now my assistant has slowly snared the tumor, and we expect some amount of bleeding. And yeah, it's a good snare. So we have got a good snaring of the tumor, and you can see that in this case, I'm trying to suction it out. The tumor, generally, you can either use a cryo extraction, but if the tumor is pretty much coming with a simple suction, then that makes the things pretty easier. Now you can see that I am suctioning out the tumor fragment to the rigid bronchoscopic barrel. Now the tumor is out. So again, I am reintroducing my scope inside the rigid barrel to see the status following tumor snaring. So in this case now, if you notice that we are also using another Fogarty balloon to occlude the airway from where it was snared to help in some sort of a tamponade. So now, after the first snaring, we still have a residual tumor left in the airway. So I am doing a repeat snaring of the tumor, and so right now we are able to snare the second part of the tumor, and right now I'm using the cryo to gently extract this tumor from the airway. And cryo is a very versatile instrument which can help in a lot of steps in the interventional procedure involving the tumor debulking. Now I have removed the tumor and I am reintroducing my bronchoscope, and now you can see that there is some sort of a residual tumor, but we are able to recanalize some subsegments of the airway. So I am suctioning out all the secretions. I'm instilling some saline to remove all the post-obstructive secretions which are present inside the airway. Now you can see that a portion of the airway has been recanalized. So now you can see that I am passing the Fogarty one through the working channel, as well as we have another Fogarty which is occluding the other lung. This is a technique which we follow in our setup. That is not something universal. So this double Fogarty technique helps us to make sure that one lung is selectively occluded from the blood spillage, whereas the other Fogarty through the working channel helps in tamponating the airway, so that there does not occur significant, that there is not a significant bleeding from the site of the snaring. So right now we go for a repeat check bronchoscopy, and you can see that the airways are pretty much open, except from the part from where the tumor is actually occurring. So sometimes we don't need to get full recanalization if we are able to attain a functional um, we are able to provide functional benefit to the patient. That should also be sufficient. So right now what we are doing is whatever the residual tumor that is there, we are ablating with the help of an electrosurgical cautery. So I make sure that the FiO2 is less than 0.4, and the set watt should not be more than 20 to 25. That's what the practice we follow at our center. And now you can see that I'm coagulating the tumor base with an anticipation that the tumor doesn't recur from where I am coagulating. The coagulation also helps in attaining a local hemostasis. And now you can see that after repeated electrosurgical coagulation, almost the entire tumor base is coagulated. There is no evidence of any sort of an active bleeding which is coming from the part where it is coagulated. And we make sure that an adequate hemostasis is achieved before we come out of the procedure, because that is very important, especially when you're doing a case of a tumor debulking, to make sure that we don't have an active hemopsis at the end of the procedure. So again, I instill some amount of cold saline as well as an adrenaline, and now you can see that the lingular lobe is clearly recanalized. Since the tumor is entirely arising from the left upper lobe, there is no point in debulking the left upper lobe tumor, because it is arising from the parenchyma. So anyway, we are successful in mitigating the hemopsis associated with the tumor, as well as recanalizing the lingular lobe. So right now I am instilling the saline to the inside the lingular lobe to remove the pent up secretions occurring as a result of post-obstructive pneumonitis of the patient of the lung. So right now it is done, and now you can see there is a very clear visualization of the lingular lobe bronchus, as well as there is a complete hemostasis which is achieved So our tumor debulking has been successful in this case. The primary objective of recanalization of the airway as well as the debulking of the tumor is pretty much achieved at the end of the procedure. Now, as you can see from here, I am doing a check bronchoscopy to make sure that there are no remnant tumor fragments which are left in the airway. And I'm passing and you can see that I'm using the corkscrew motion to gently remove the rigid bronchoscope from the airways to make sure that we do a repeat check bronchoscopy once the patient is put under LMA again. So the rigid bronchoscopy is removed from the patient, and now we have put a LMA, and through the LMA now I am passing my bronchoscope to make sure that we have attained a complete recanalization of the lingular lobe, and to look for any sort of a residual blood clot or the tumor which can impede the post-operative outcome. So the right main bronchus and the right upper lobe and lower lobe bronchus appears to be normal. And right now I'm passing my bronchoscope onto the left main bronchus, and you can see that the tumor is clearly removed, and we got a good recanalization of the lingular lobe bronchus. And you can also see that the tumor from this arising from the left main bronchus is completely coagulated, and we are done with the procedure, and now the patient will be extubated on table, and most probably he should be discharged the very same day with proper post-op. I thank one and all for attending this web meet. I hope this web meet would have enriched your learning in interventional pulmonology. We hope to connect with you soon for yet another web meet next month on a different topic of interventional pulmonology. Until then, goodbye and greetings from India and from Dr. Visweswaran from Yashoda Group of Hospitals. Thank you.